Hello, I am Dr. Anand Mamdani from the Department of Neurology. This is the first module in the series of altered mental status. It focuses on introduction to altered mental status and various states of altered consciousness. This module has three objectives. After finishing it, you should be able to define altered mental status and important terminology associated with it, describe neuroanatomical pathway for maintaining consciousness, and define different states of consciousness including delirium. At first, we are going to talk about important terminology that we will be using in this module and the other modules of this series. You may know most of them. Attention is the ability to focus on specific stimuli to the exclusion of others. Awareness is the ability to perceive or be conscious of events or experience. Arousal, which is a basic prerequisite for attention, indicates responsiveness or excitability into action. Consciousness, which is a part of arousal, means clarity of awareness of the environment. And finally, confusion is the inability for clear and coherent thought and speech. Altered mental status is a broad term used to define disorder of consciousness. Consciousness is defined as a state of awareness of self and surrounding. Alteration of consciousness are of two types, one involving arousal, which is level of consciousness, and second involving content, which involves cognitive and affective mental function. In this series, we will be talking about alteration of consciousness associated with arousal. Alteration of arousal is also known as altered level of consciousness. There is no discrete level, but a continuum of subtly changing behavioral state that range from alert to comatose. Different provider or different literature would use different terminology for each alteration, but mostly involves sleep, obtundation, stupor, and coma. Alteration of content causes dementia, delusions, confusion, and inattention, which will be discussed in a different series. Consciousness is maintained by the neurons in ascending reticular activating system involving lateral medulla, dorsal pons, periaqueductal gray matter of the midbrain, and arousal centers in bilateral thalami, which sends projection or tracks throughout the bilateral cerebral hemisphere. Any injury or abnormality of these pathways can cause altered mental status. Level of consciousness has two components, arousal and awareness. In a basic terminology, you can define whether patient is awake or not. If patient is awake, whether patient is aware and oriented or not. If patient is not awake, whether patient is arousable with verbal stimuli, tactile stimuli, or painful stimuli. If patient is arousable, whether patient is able to maintain arousal without stimulation or not depending on the response. What you get, level of consciousness divided into alert, sleep, obtundation, stupor, and coma. There are other abnormalities or altered level of consciousness known as acute confusion state or encephalopathy and delirium. We will discuss all these states in this module. Patient is alert if he or she is awake, oriented to time, place, and person and situation, and optimally responding to stimulation. Acute confusional state, which is also known as encephalopathy, is described as inability to think with usual speed, clarity, coherence, and there would be some degree of inattentiveness and disorientation, and difficulty performing complex tasks and may show poor comprehension. For example, Mr. X is awake lying in the bed, but when you ask him where he is, He would say in his house or in the mall or office, or he will tell you different date, or wouldn't know why he is in the hospital. This is a typical example of acute confusional state. Delirium is a Latin term which means out of furrow, meaning derailment of mind. It is defined as an acute mental status change characterized by abnormal and fluctuating attention. So, this is a disorder or disturbance in attention and in the level of awareness and reduced ability to direct, focus, sustain, and shift attention. It is most common behavioral disorder in the medical and surgical setting, especially post-operative patients who are old, on pain medication, or has some baseline brain damage or psychiatric issue. Usually, initially, a person would be disoriented to time, then to place, and then to person. Most common clinical characteristics of delirium are acute onset of mental status change with fluctuating course. At one point, they will be alert, and the next time, disoriented or lethargic, or very agitated. They would have attentional deficit, causing confusion and disorganized thinking, perceptual disturbances, disturbed sleep wake cycle, disorientation and memory impairment, and other cognitive deficits, which in turn would cause behavioral, emotional abnormalities, and their level of consciousness might be affected as well. They may have some altered psychomotor activity, and depending on psychomotor activity, delirium is divided into three subtypes. First, hypoactive delirium, which is seen in 35% of the cases of delirium, would have psychomotor retardation causing lethargy and decreased arousal. They will have sleep-wake inversion, which is also known as sundowning, where person would be awake during the night and sleeping during the daytime. Second, hyperactive delirium, which is seen in 15% of the cases. Patient will be hyper alert and agitated, will be disoriented and have a motor restlessness, fear, anxiety and irritability. Would have overactive autonomic nervous system causing tachycardia, hypertension, tachypnea or fever, and they may have delusions or hallucinations. Third, mixed delirium, which is most common and seen in 50% of the cases, is alternating hyperactive and hypoactive delirium. So the patient either would be sleeping at one time or will be awake and up and agitated and combative at other times. Sleep, defined by Lucretius 2000 years back, is absence of wakefulness. Later on, Magnus in 1830 defined that sleep is not just an absence of wakefulness, but it's a suspension of sensorial power in which the voluntary functions are absent, but the involuntary functions such as circulation, respiration, and other functions controlled by autonomic nervous system remain intact. Most of the patients in sleep are arousable with verbal stimulation. Sleeping patient also sometimes be called a somnolent, but lethargic or drowsy patient would need more than just a verbal stimuli to keep them awake. Obtundation comes from the word obtund, means dulled or less sharp. Obtunded patient would have mental blunting with apathy and inactivity, which means they have mild to moderate reduction in alertness accompanied by reduced interest in environment. They will be arousable to repeated tactile stimuli but will be slow to respond to stimulation. They may have an increased number of hours of sleep and may be drowsy between sleep bouts. Typical example of obtunded patient is sleeping on the bed, won't respond to verbal stimulation, but when you touch them or shake them, they would wake up and then be able to answer your questions. Stupor is a Latin word which means to be stunned. It's a sleep-like state but not unconscious with little or no spontaneous activity. It is a condition of deep sleep or similar behavioral unresponsiveness from which subject can be aroused only with vigorous, painful and continuous stimulation. Even when maximally aroused, the level of cognition function may be impaired and left unstimulated, patient will drift back to sleep like that. Typical example of stuporous patient is sleeping on the bed. You shall speak their name or shake them. They will not wake up. You give them painful stimuli, either by pinching them or pressure on their sternum. They would wake up but not fully and wouldn't be able to answer your questions appropriately, like telling their names or whether they are there or what time it is. Coma is a Greek word which means deep sleep or trance, is a state of unarousable unresponsiveness in which patient lies with the eyes closed, cannot be aroused to respond to appropriately to stimuli, even with vigorous stimulation or painful stimulation. It's a state of sustained, usually greater than 1 hour of absence of arousal and awareness. The patient may grimace to response to painful stimuli and limbs may demonstrate stereotyped withdrawal response, but patient doesn't localize or make discrete defensive movement. Typical example of patient in coma is patient is lying in the bed with eyes closed and is not arousable with verbal, tactile, or painful stimulation and doesn't answer your question, doesn't speak, and have their eyes closed. So, in summary, altered mental status is a broad term used to define disorder of consciousness, and there is no discrete levels but a continuum of subtly changing behavioral states that range from alert to comatose, including sleep, obtundation, stupor, and coma. Consciousness is maintained through the projection of neurons from ascending reticular activating system and arousal centers of bilateral thalami to bilateral cerebral hemisphere. There are different levels of consciousness depending on wakefulness or arousal and awareness. Alert is the patient who is awake and oriented to time, place, and person. Acute confusional state or encephalopathy is defined as a patient who is awake but inattentive and is disoriented and has difficulty performing complex tasks. Delirium is an acute mental status change characterized by abnormal and fluctuating attention depending on their psychomotor activity. It's subtyped into hypoactive, hyperactive, and mixed delirium. Patient in sleep would be arousable with verbal stimulation. Obtunded patient would be arousable to repeated tactile stimulation but would have reduced interest in environment. Stuporous patient would be able to be aroused only with vigorous painful stimulation. When left unstimulated, will drift back into sleep like state. Coma is a state of unarousable unresponsiveness in which patient lies with eyes closed, cannot be aroused, wouldn't respond to stimulation appropriately. Additionally, I would recommend you to go through these resources, which is Neurology in Clinical Practice, Chapter 5, Stupor and Coma, available at Rowland Library ebook, as well as Disorder of Consciousness, Clinical Practice on Osmosis.